Hi there, I'm the neuromuscular mechanic, and today I want to talk about ultrasound guided injections for Quervain's tenosynovitis. So, as the name suggests, we're using these injections for Quervain. So, this is a painful condition that's affecting the first dorsal extensor compartment. So, that is the compartment that has the tendons for the abductor pollicis longus, or APL, and the extensor pollicis brevis, or EPB. Whenever I do my injection videos, I like to go through a checklist, and we'll do that today. So, what the ideal patient position is, what transducer to use, how to start with surface localization, structures to identify on pre-scan, and how to get after your target. And appreciate that the videos that you see today are of myself. With patient positioning, I'll have patients on their back in a supine position, provided they have no shoulder issues, their arm abducted to the side, with the ulnar aspect of the wrist laying on the table so that the radial aspect where I'm doing my injection is free to access. With the transducer, I'm going to use a high frequency linear probe because these structures are superficial. Ideally, a hockey stick probe if you have one for that small footprint. With surface localization, if you know where this is, you can start in short axis from the intersection between the first and second dorsal compartments. That shows up really well on ultrasound. Once you've found that, then you could scan distally following that first compartment. If you don't know how to find it, you could also start at Lister's tubercle in short axis. Just radial to Lister's tubercle will be the second dorsal compartment, and then you could follow that proximally to get to that intersection from where you can find the first compartment. When it comes to the pre-scan, we want to identify the radius. We want to make sure we identify the radial artery because we want to avoid that with our needle pathway, particularly if we're doing an injection in plane short axis. Depending on the resolution of your ultrasound, you may be able to identify the superficial radial sensory nerve, and then be confident that you're identifying the APL and EPB tendons because we want to be in the tendon sheath. So those are things to look for with your pre-scan. Now, once you've identified those tendons, we're doing injections in plane, and we're injecting under the tendon sheath but not into the tendons. And this can be done in short axis or long axis. Short axis, you can enter dorsal to volar or vice versa. This, to me, is the preferred approach because you can really appreciate the tendon sheath versus the tendons much better than the long axis image, and we'll go through this. So in a second here, I'm going to start with the ultrasound video, and we're just going to pause. So here I am in short axis, and what we've identified here is that intersection with the second dorsal compartment, the ECRL and ECRB tendons. That are just sort of above the bony contours, and then above it is the first dorsal compartment. So that's what we're interested in. That compartment has the APL tendon and the EPB tendon. And so what I'm going to do now is I'm going to take this probe in short axis and I'm going to scan distally following that first dorsal compartment. So here I go, I'm scanning a little bit distally, and we'll just sort of pause. So on the left of my screen is sort of more ulnar. The right of the screen is more radial. And so what we have is our EPB tendon, that hyperechoic appearance, as well as the hyperechoic APL tendon. And so there is, that's how you could identify them. And so certainly you can do an injection here in short axis. I'm going to go through this a little bit later in the video series. But what you can do is, if you were doing a long axis injection, is you could line up one of those tendons and basically rotate the probe 90 degrees. And that's what I'm going to do here shortly. So here I go, keeping that area sort of fixed in the middle, and now I'm rotating 90 degrees. And there you can sort of see that sort of appearance of the tendon, sort of that railroad track appearance. And there is my first DC, or my first dorsal compartment. And keep this in your mind, but it's really hard to appreciate the tendon sheath from the tendon, particularly what's tendon sheath and what's overlying soft tissue. But you could certainly do an injection in plane. It doesn't matter if you're going from more distal to proximal or proximal to distal, but you're trying to, again, inject to that tendon sheath but above the tendons. And so your needle pathway might follow this. And certainly this could be very reasonable. It can be very hard sometimes to do injections in short axis when you don't have a hockey stick probe, just given the footprint. Now, what I'm going to do shortly is go back to a short axis view. Now, I've sort of idealized this, but here we have on the radial aspect the RA, or the radial artery. So if I'm going to do an injection sort of in plane, I certainly want to avoid the radial artery. So just be aware of where it is. Now I'm going to go back to the tendons here, so sort of going there, and we just sort of pause. I have sort of a vein there that's collapsing on the left of the screen, and again, radial artery on the right of the screen. So we'll go back, and there we got sort of the image. So there we have the bony contours of the radius. We have the overlying EPB and APL tendons, and then that needle or red arrow pathway, which is simulating the needle track pathway, is going to the tendon sheath, which is this sort of anechoic area that surrounds the tendon. And you can appreciate that it's much easier to see the tendon sheath in this short axis image than the long axis, which can make you more confident that you're doing the injection correctly. But understand that depending on the footprint of your ultrasound, this short axis technique can be difficult. But again, you're trying to bring it to that tendon sheath, that hypoanechoic region, and not into the hyperechoic tendon. So that concludes the videos today. I'm the neuromuscular mechanic, and I hope you found today's video series handy. Take care.